so, we set our objective to see if whether endoscopic vein harvesting of GSV provided improved post-operative outcomes compared to open vein harvesting in patients undergoing lower extremity arterial bypass. To do that, we did a search strategy, including patients undergoing lower extremity arterial bypass with either EVH versus OVH, and we saw both RCTs and observational studies. We searched 4 databases: PubMed, Embase, Cochrane Central, and Web of Science. We registered our systematic review in Prospero and carried on with the search. For our primary outcome, we did a 1-year graft patency. Was either primary assisted, or secondary patency. For secondary outcomes was length of stay, mean operative time, and wound complications. For statistical analysis, we did a random effect model using risk ratios and mean differences with a 95% confidence interval, and statistical significance set at p less than 0.05. We had 662 result articles to be screened, of which 13 retrospective cohort studies met our eligibility criteria. It comprised 12,401 patients undergoing 12,419 procedures, of which 27% was EVH and then 73% was OVH. So we have the pooled results for patency. We have primary assisted, and secondary patencies, none of which showed a significant difference in patency. For length of stay, we have similar results, nothing significantly different in either total length of stay or post-operative length of stay. And we get to operative time, and we see that EVH patients had a significantly increased mean operative time when compared to OVH, but it also showed that in wound complications, patients undergoing EVH showed a significantly less incidence of wound complications. So that was very interesting. This led to our conclusion to have that EVH demonstrated to be non-inferior at a 1-year graft patency when compared to OVH in lower extremity arterial bypass, and may reduce complications in the patient undergoing this procedure. Also, EVH was associated with a significantly longer operative time, but further randomized studies are warranted to establish its role as a new minimally invasive procedure and an alternative to OVH. Our study had some limitations. The first key limitation was that our study relied only on observational studies due to a lack of randomized trials on this topic. We couldn't do subgroup analysis due to a lack of data, and we also couldn't control the fact that EVH and the experience with this procedure in every center is known to affect the outcome of it, but we couldn't do a controlled analysis of this. So findings of this study should be interpreted with caution, as these studies are inherently more susceptible to biases, confounding selection bias and measurement bias. I want to thank my co-authors here, that they come from every part of the world, and thank you for your attention today.